Insulin dose titration regimens, etc. I'm Mayor Davidson, and my colleague here is Dr. Vahid Mahabadi. We are going to talk to you about 5 separate insulin regimens. That gives us 8 minutes apiece. I'm going to be very ruthless with the timer, and hopefully we're going to end up on time. These are our conflicts of interest. Just some background information about adjusting insulin doses. There really is no one right way to do it. You just got to get to the right target. And here's a key point, that we adjust the insulin doses around the patient's usual eating patterns. We try to improve the eating patterns, but it's not a good idea to give them a certain set insulin regimen and now make them change their eating pattern to try to match that. And the inconsistent food intake is a big problem, as we all know. And also the response to insulin is really very variable. Well, we've done studies and other people have done studies that if you give the same dose of insulin to the same patient from day to day, there is a 20 to 25% variability in how they respond. And because of that, we need to use the pattern of glucose results over time. You just can't take 2 or 3 numbers and make a decision. And finally, preprandial testing is, this is my opinion anyway, easier than having to do postprandial testing. For instance, all of you ate lunch at about 12:30 and it's now time to do your blood glucose, but you're sitting here in the middle of a conference. But if you were out there and at a break where you're going to eat supper, then you would be much easier to do it. If the A1C is too high, but the preprandial values are at their target, then we would go to postprandial testing. So what we're going to do first is talk to you about something called BEDO, which is bedtime insulin, daytime oral agents, and Dr. Mahabadi is going to lead off on that. You all have 2 handouts, I'm sorry, about there's 2 ways to do this, and it's in your packet.
Good afternoon. You have the handout. This BEDO algorithm has been developed by the endocrinology workup group, and then essentially it's very clear. You can just read about it, and then if you have any question, you can ask. But overall, we recommend that if the A1C is between 8 to 10% for about 3 months, then you notice that fasting blood sugar or postprandial or preprandial blood glucose doesn't improve, better not to push it and just change the strategy. And then one of the best one is that we start insulin therapy while patient is on max dose of the oral agent therapy. Then we recommend, based on our possibilities in the county, to start NPH, and for sure to do some changes to the medical regimen. Then the one that we have in the county is metformin. It's glimepiride, glipizide, and pioglitazone. Also from our community partners, sometimes we get patients on DPP4 inhibitors. Then the recommendation is that at the time that we start the insulin therapy, after 3 months, which the A1C doesn't improve, then to continue with sulfonylurea, but we can stop DPP4 inhibitors. Also, we can reduce pioglitazone to the 15 milligram, since pioglitazone with insulin both increase the intravascular volume and can cause some exacerbation of the heart failure. These are the recommendation has been done. And then the main issue is that with the insulin therapy, we have 2 handouts for you based on the weight and also the level of the A1C. We recommend to start the BEDO or twice daily NPH. As you see in the step C, if the blood glucose is less than 80 milligram and the symptoms of the hypoglycemia is there after you started the NPH, we recommended to decrease the insulin by 4 milligram. And always remember that although we manage the diabetes, the first goal is that not to have hypoglycemia, because hypoglycemia is more dangerous. And between 80 to 89, although we modify this, also there is a, I need to explain this, that hypoglycemia defined 70 or less, but here have a safety cushion, we just pick the 80, and then we start from the 80. 80 to 99, 2 units, between 100 to 140, no changes. There are some controversy here. Some people prefer 130, but it's fine. Then 140 to 160, again, we go by 1 unit, subsequent step 2 units and 3 units. If the patient is overweight or obese, BMI is over 30, because of the for sure insulin resistance, we are going to be more aggressive in increasing the dose. But again, as you notice, we are as aggressive in adjusting the dose in hypoglycemic state. And then if it's going to be less than 80 milligram, we drop 4 units insulin in order to avoid hypoglycemia. I think that should be enough for this. I mean, if you have any other.
I should have mentioned that the general format is going to be that each one of us will talk for about 6 minutes about our particular insulin regimen. The other person then gets to add comments for a minute, and then we're going to try to, if you have comments for you for a minute. So the difference then between the simplified one, which I'm going to talk about, and the one that Dr. Mahabadi just talked about, was that if the fasting glucose is above 140, regardless of what the number is, then we would just go up on the insulin. And as you can see from what's handed out, it's a little bit less aggressive. We only go up by 2 units each time for the people with a BMI less than 30, and 3 units with a BMI greater than 30. And by the same token, we decrease by the same amount if it's over, if it's less than 100. If once you get the fasting glucose down to target level, there's 2 ways to go. One is just to wait 3 months and see what the A1C is. If you suspect that the patient is probably going to be too high, you can then measure glucoses before supper, and if they're high, we use about 180 or 200, then you know that the BETO is probably not going to work on it by itself. We have about a minute, and are there any questions about this BETO, bedtime insulin, daytime oral agents?
And it is for a long time.
So the question is continuing the sulfonylureas with the insulin and hypoglycemia. The key, as I mentioned this morning, is you want to have the pills during the day do the best job it can in order to keep the daytime glucoses down. But that's a good point. If the patient gets hypoglycemia during the day, then you've got to lower the sulfonylurea agent. So the bedtime insulin, you really focus on the fasting glucose, and if they get hypoglycemia during the day, it's the sulfonylurea. Good point. John? The evidence in the literature, I'm not aware that it's less hypoglycemia than glipizide. I don't think they've even been checked head to head. Yeah, glyburide for sure. Okay. The next. We've run out of time. Oh, Despino, real quick. Okay, the choice of insulin. NPH at bedtime will do it. It's cheapest. You can use Lantus, and if you can get flex pens, that's really great. Detamir, you often have to give it twice a day instead of just once a day. John asked me afterwards, we got to stay on schedule. Okay, so the next insulin regimen is going to be self-mix split. And in the slides that I'm going to use, we have an ideal patient who measures twice a day, measures preprandially, and the time is on this axis. The preprandial targets, low and high, are here, and the postprandial targets are here, but for the purposes of teaching here, it's going to be preprandial. So this is a self-mixed insulin regimen on 30 in the morning and 10 of regular before breakfast, and 20 of N and 10 of regular before dinner, and the patient's obese. So you all have 30 seconds now to determine how you're going to adjust these insulin doses. Okay, how many would change the morning NPH? Put them up high so I can count them easier. A minority, but some would. Okay, change by, raise your hand if those who wants to change it. 1 unit, 2 units, 3 units, 4 units, going once, going twice, 5 units. So we have some very hesitant 4 and 5 units. Okay, how many would change the morning regular? Nobody. Okay. How many would change the nighttime NPH? Hesitant, but we got a couple over here. And how many would change the nighttime before dinner? The regular before dinner. Some more would. How many units? 1, 2, 3, 4, 2 here, 4 here. Okay, most of you wouldn't change the insulin dose, and your patient is going to continue with their high A1Cs. Here's the analysis. The overnight, the preprandial glucose before breakfast. So let's give you some colors here. If it's blue, it's low. If it's green, it's in target. And I should have mentioned the targets are the 88 targets. Actually, they're not. We used 120 actually. The light rose color is high, and very high is the darker color. So it's high before breakfast. Therefore, you should be changing the overnight NPH. So let's look at the recommendations down here. Before breakfast, we increase the NPH by 8 units from 30 to 38. Now that's a pretty high increase, except that, remember, the NPH in the morning affects the before supper. And look at, most of them are very high. That's why we go up so high. Before breakfast, we increase it by 4 units because the majority of these are high. Before dinner, it involves the before breakfast test. Look, they're all high. You should go up on that by 4 units. It's an obese patient. At least that's what we would do at MLK. And before dinner is high. And very few people raised the insulin dose. So this is what should be done. We're going to get questions at the end. This is what should be done, in our opinion, and you all didn't do it. Okay, look at this pattern. All right, how many are going to raise the NPH insulin or change the NPH insulin in the morning? I got a little more aggressive people here. Okay. How many are going to change the regular? How many would vote to do that? Just a couple. Okay. Change the regular. Good point. All right. Those that would increase it. Those that would decrease it. Right. The NPH before dinner? How many would change that? Not many. And how many would change the regular before dinner? We have just 1 would change it. Okay. Now let's look at what happens here. So most of the fastings are okay, and therefore you would not change the Humulin before dinner. These are mostly low, and the people who wanted to decrease the regular before breakfast were correct. Here we have too high. So you should have increased the NPH before breakfast. And this patient is on 80 units, and so we don't go up by the usual 4, we go up by the 10%. So we went from 80 to 88 units to make sure these came down, and we did not change the regular before supper, because the before bedtime sugars were okay. All right, you get one more shot at this. All right, so this one's a more complicated one. He's on 20 of N in the morning, 6 of regular before breakfast, 10 and 8 before dinner, but he gives you the history that between 1 o'clock and 3 o'clock in the morning, he wakes up sweaty, he gets hypoglycemic, and this occurs 2 to 3 times a week. All right, how many would change the NPH before breakfast? Okay, not very many people. How many would change the regular before breakfast? A smattering, but some would. How many would change the NPH before supper? Okay, so if you're going to change the NPH before supper, how many would raise it? How many would decrease it? Okay, and regular before dinner? And you would change it, and what way? Okay, so John wants to have it go down because he thinks it affects the 1 to 3 a.m. hypos. Well, here's the analysis. So he's high overnight, and so he's low before. Well, there should be hypos here. They put the wrong thing in the computer. There should be hypos. Now, those of you who are older, like I am, heard about something called the Somogyi reaction, which is when a patient gets hypoglycemic and doesn't know it, there's a rebound hyperglycemia. You can almost erase that from your vocabulary. There have been 3 or 4 studies that have actually taken blood sugars overnight, put them down into the 30s, and there is no big rebound. It goes up to about where it was before the patient went to bed. And so decreasing the NPH before supper is probably not the answer. The answer is to move the NPH from before supper to bedtime. It then peaks right around when the patient's eating breakfast. Okay, and then so we would continue the human N in the morning because this is okay. We increase the human R because this is high before lunch. They would say to increase the N because this is high, but because of this hypoglycemia you don't see up here, I would move that to bedtime, and I would just continue the human R before supper. There is some data in the literature that if you give regular before supper, you can cause early overnight hypoglycemia, and that's what Dr. Tayak was referring to. Okay, we didn't give you much chance to comment on that because we got 7 seconds to go. I'll let it ring so you know that we're on time. Ta-da! Okay, our next regimen. I'll get it.
Okay. Hello again. I be present this case about November 7 in Phoenix, Arizona. This is actually a review of everything since we had so far. Then John is a 62-year-old African-American gentleman which has been diagnosed with type 2 diabetes for about 10 years and has irregular mealtime, smokes, also has comorbidities as CAD, depression, and hypertension. He reports in the visit that he feels anxious, sometimes no clear reason. At these times, he has become clammy, tremble, and also become sweaty. BMI is 30, right at borderline, blood pressure elevated, review of system negative except poor sugar control. Current lab A1C 9.4%, fasting plasma glucose is 180 to 200, and pre-meal 200 to 250 milligram per deciliter, and creatinine 2.3. What is the medication? The one that we concern here is metformin, glimepiride, and sitagliptin. Why he's complaining of the trembling, sweating, and clammy? Is it hyperglycemia, hypoglycemia, or hypothyroidism, or he has GERD? He has to change the position at night. Huh. I think this is the classic symptoms of hypoglycemia, and this is the self blood glucose monitoring, which shows many hypoglycemic episodes. As you see, many of the values are below 70. Then the reason is that chronic kidney disease, and also he's on almost max dose of sulfonylurea, glimepiride. Then again, one more time, A1C 9.4, triple therapy, and no success. Then we have to do two immediate changes. Number one is stop metformin because of the chronic kidney disease. And sitagliptin also, I don't know how useful is it to continue, but anyway, 50 milligram is the recommendation for chronic kidney disease dose. But some people continue with insulin therapy, some not, and the argue is that decrease the potential need for the bolus insulin, also reduce the glycemic variability, especially postprandially. Then this patient need to be on insulin. First step, basal insulin. Then has been started on 10 units of the insulin at the bedtime, which is a generic dose and usually is safe for everybody. Even you can close your eyes and start patient on the 10 units basal insulin. Then ended up to us, and then also has received some education about the diet and lifestyle. After 3 months follow-up, with only basal insulin, A1C from the 9.4 dropped to 7.9%, and creatinine almost the same, 2.3. Medication at this time is sitagliptin, 50 milligram, which is renal dose. Long-acting insulin started from 15 units at the bedtime, now is currently up to the 34 units at bedtime. And this is the only medication for diabetes management that he receives. These are the SMBG log. As you see, fasting numbers are okay, not at goal, but still, 60% of them. Oops. Okay. But post-lunch, post-dinner, and bedtime, none of them are goal, and majority of them are over 200. Then this patient needs basal insulin. And also there are a study has been done when patient, the A1C gets around 8, then pushing that A1C down is a little bit difficult without, management of the mealtime insulin. Has to be focused on the mealtime insulin in order you are going to be successful. Let's see.
What about sitagliptin?
Oh, sure. How about it?
You're going to cost him time. He only has
Yes.
2 more minutes.
2 more minutes. Okay. Then, what is the best option at this point? Increase the basal insulin for sure not, but the best option is going to be either start basal and bolus. Basal and bolus. We can add also prandial insulin at the largest meal, or we can switch to the premix, which Dr. Davidson discussed it. Then we start rapid-acting insulin analog, which is some people prefer, is better, especially is more coordinated with the time of the food absorption. Then usually 4 units or 0.1 units per kilogram, or for every 15 gram of carbohydrate, 1 unit is going to be a safe practice. But we have to stop sulfonylurea. Make sure patient on on bolus insulin not to be on sulfonylurea. This is the way that analog insulin works. This is the regular insulin, and the studies also shows that it's more corresponding to the timing of the food absorption. Anyway, after 3 months, A1C 6.4%, fasting plasma glucose 94 to 100, and 110 to 118. I'm going to stop here, and this is the medication which he's giving right now.
Okay, so I got 1 minute to comment. So some people we give our patients the choice of basal bolus, which is 4 injections, or 2 injections, as I mentioned earlier, the majority actually select the 2 injections. But it's been suggested that you could just start with a bolus insulin before the biggest meal. And then if you need another one, then you add it for the second, and then the third one, you add it for the third one. A study was just done looking at that, and 75% of the patients eventually ended up on all 3 shots, and it took at least 8 months for them to come down to the target A1C. So that's nice in theory, but in practice it doesn't seem to work out. So we usually just start them on 3 shots a day, although you could do it the way I just said. Okay, we've got about a minute now for questions.
Felt like 1 shot. Okay, I'll do 1 shot.
I got you. And that's been, in our county population, that's been a problem. Her point was 4 shots a day can be difficult for patients.
No.
Repeat the question.
He's asking if we stop the sitagliptin when we start the... No, we didn't stop it, again. I mean, it's 9.2, but it's still on sitagliptin, and the 34 units of the basal insulin, A1C was down to 7.9, which is almost 8.
Okay. We ended up 15 seconds early on that one. Oh, we got a question. I'm sorry. Go ahead. No, it shouldn't have been. We don't add 20 units of insulin. There was a mistake on the slide? Right, on my first case? Okay, no, we shouldn't go up 20 units. John, look quick.
A lot of my patients won't take insulin at night. They take it 3 times a week. If you look at pharmacy data, they take it rarely. So I've moved a lot of my patients in the morning. They wake up, they have coffee, take your basal in the morning. I find it very successful. Can you comment about that? Wake up, check your sugar, one down.
No, the data are that you take it once a day if it's glargine, and no matter when you take it, it doesn't make it. But no matter when you take it, or if you take 2 shots a day, you still use the fasting glucose to change the dose, and you just change each dose half the amount. Well, I'm going to talk about pre-mixed insulin now, and we don't use it at the county at MLK. I discourage it. And I'll show you why. But anyhow, this patient's on 40 in the morning and 30 in the evening, and these are the results. All right, everybody made a decision? Okay. How many would change the morning dose? Okay. Very, very few, but some would change the morning dose. How much? 2, 4. Raise your hand when you get to your right. 5, 6, 7, 8 units. Oh, up to 8 units. All right. How many would change the evening dose? More. Okay, but not everybody. Alrighty, let's look at the analysis. So, the morning is too high. They're all too high, and the evening is before bedtime is very high. And so, we would increase the 70-30 by 6 units at least in the morning, and by 10 units in the evening. Now, the problem potentially here is that you'd probably be okay because you're high here, but in order to get a lot of fast-acting insulin to act before bedtime, you only have 30% of your increase is going to go for that particular one. Okay, here's the next one. All right, everybody ready? How many would increase, or how many would change, let's put it this way, how many would change the morning Pre-mixed. You have a very firm yes in the back, but many people are raising their hands. How many would change the before dinner pre-mixed insulin? Okay, you're going to increase or decrease? All those that would increase. All right, 2, 4, 6. This is the units now. 8. Oh, 8 units. Okay. All right. Here's the analysis. So, we would decrease the Novolin 70/30 by 6 units from 40 to 34. And here's the teaching point here. Even though your post-breakfast is high and you want to increase the component that's fast-acting, you are limited by what's happening before in the afternoon. So you cannot increase this. Any lows drives the whole issue. And we would increase the Novolin of 70/30 before supper because this is too high and you want to get this down. You're probably going to be all right because even though it's okay before bed, only 30% of your increase is going to go to that. Okay? Third patient. All right. How many would change the morning dose? All right. How many would increase it? Good. I guess the rest of you guys would decrease it. Okay. How about the evening dose? How many would change it? Okay. Some of you would, a fair amount. How many would decrease it? Nobody. How many would, you decrease it? No. How many would increase it? Okay. So here is the analysis. So it's okay overnight, and so we would decrease it in the morning dose. Let's take that one first. Again, because we're low here, and so we're decreasing it here, and we are increasing it at night. And the potential problem is that you're okay overnight, and you're increasing it really to take care of this before bedtime high sugar, but again, only 30% of it goes there, as opposed to 70% going toward the overnight, and the potential of hypoglycemia then, of course, is more increased with that. And so that limits the ability, I think, of premixed insulins to really control patients tightly because you can't change them individually. All right. Any comments? Okay. We have time for some questions. Well, I didn't plant this question, but it was, would the patient be better off from using a self-mix than premix? And I think the answer is obviously yes. In this case, you could have decreased the regular in the morning, and in one of the other cases that we had, in this case, you could have decreased the morning NPH and increased the regular. In other words, the morning NPH would have been decreased because of that, and the regular would be increased because of that. And I have to tell you, I tried to get the people that wrote the guidelines to use self-mix split insulin. They wouldn't write it. They said no one uses it anymore. In the county, we just did an analysis, and we use 2.5 times more NPH than we do glargine, and 3 times more regular than we use Lispro. Okay. Well, any of my nurse practitioners here? Well, I can't. I'm fortunate. I can't answer that because we have nurse practitioners, and it's very difficult when they can't read and write. But they work so well with those patients. They keep at them, bringing in family members and all the things I'm sure you've tried. It is a problem. No doubt about it. Okay.
Okay, next topic is insulin U500. I would like you to get familiar with this because in pipeline we have insulin U200 and U300 is coming. Then This is one of the oldest insulin which has been invented in 1952, but has been reapproved again in 1997, and currently is a very good tool for patients with high insulin resistance. Then all the insulins, as you see here, is U100, but U500 means every 1 unit of this insulin is equal to 5 units of all our insulin that we have. Then 5 times is more potent, and the same way the volume which we are going to inject is going to be less. Then the time of the action reflecting both prandial and basal activity, usually in 30 minutes peaks, and this property is due to high concentration, and really this is regular insulin and hasn't been modified by any agent. The candidates are, especially in the era of the obesity and insulin resistance, mainly they are patients with the severe obesity or high requirement of the insulin, more than 200 units daily. We consider them for insulin U500. Also, there are other potential candidates like high-risk pregnancy clinics with severe insulin resistance, or other genetic defects tests which we don't get to it now. Then how we inject, one of the main issues is that the insulin syringes, we don't have U500 insulin syringes. Then the available one is U100 regular syringes which we use, and also the other one is tuberculin syringes which some authorities recommend for the safety issues. It's a sub-Q. Usually patient needs 2 to 3 injections daily, and in the prescription we mentioned the unit marking instead of the actual unit. I'm going to give you an example later. As you see here, this is 100 units of the U100 insulin. This is a U100 syringes, but this is a U500 which is only 20 units of that insulin, equal to 100 units or 1 cc of this. Or if you use tuberculin syringes, 0.2 cc is going to be equal to 2 units. What is the advantage of this? Then in the case that I have, we are going to discuss, but as Dr. Davidson mentioned in the morning, when the volume of the insulin is high, especially when we go beyond the 100 unit, the absorption is going to be unpredictable. Besides that, patient complaining of the pain because of the volume, and then this is going to decrease the compliance. That's why this insulin for situation like this is very useful. Then there is an algorithm how to start. In our protocol in the county, we start at 200, but also some authorities consider 150 is another point to start patient on more concentrated insulin like U500. Usually, if the requirement, total daily requirement is going to be 150 to 300, patient need minimum 2 injections, and usually 60-40 or 50-50, you can divide it like that. Again, same as other insulins, half an hour before meal. 300 to 600, for sure, they need more. We can split it between 3 to 4, and more than 600, the patient needs 4 injections, even 1 small injection at the bedtime. Then this is case 1, the 48-year-old male with type 2 diabetes for 15 years, BMI of 36.4, dyslipidemia, hypertension, obesity, and asthma, has been in disease management program for twice, and the second time ended up to A1C of the 7.3, has been discharged again, came back on May 2012 with A1C of the 10.9. At the time he got back, the dose was 40 units of NPH in the morning and at the bedtime, and 20 units of the regular in the morning before breakfast, and also this one as at the bedtime. Also, he was getting metformin and pioglitazone, and these are the fasting sugar and pre-dinner, which the numbers are all over the places, majority of them above the 200. Then his complaint was painful injection because of the volume, and also nightmares. Why nightmares? Hypoglycemia, exactly. Especially he was getting the short-acting insulin, 20 units at the bedtime. And then we started continue with the NPH and regular from October to February, while the requirement got to 178 units. Still A1C was 9.8. We decided before get to the 200, we changed the insulin to U500, and we started on 17 units twice a day, and blood glucose improved effectively. Then he ended up to 17 units. This is the way that we write it down. 17 insulin syringe units. In the parentheses, we have to put 85 units of U500. This is the way that DHS pharmacy wants. Before breakfast and dinner, then A1C in 2 months dropped to 6.8 and 6.6. And currently still he's in the program. And this is one of the problems that we have. We have to keep all these patients because primary care physicians, they don't accept to continue. Then we stopped the, you have time? 45 seconds. We stopped the, doctors. Yeah. We stopped the pioglitazone. The reason was that, again, concern about the heart failure, again, combination of the PPAR gamma and also insulin can lead or exacerbate the heart failure. Not in everybody, but this is a precaution that we have to get. I stop the second, please.
Okay. The comment I would make is how we use U500, and it's relatively simple. U500 insulin has a pharmacodynamic effect very similar to NPH. So we would give it twice a day, once in the morning, once before dinner, and use the fasting sugar to determine the before dinner dose and the before dinner sugar to determine the fasting dose. And we go up by 25 units each time we do it. Sometimes you get those two glucoses at target and you still have too high an A1C. And I'm not sure why this happens, but if you use Lispro or a short-acting insulin, it works pretty normally. And so we would add that to the regular, to the U500 in the morning and to the U500 before dinner. You can't mix them, so it's a separate injection. But our patients start usually about A1Cs of 8.5 or 9, and we get them down to about the mid-7s, some below that on the U500. We're a couple minutes late to go into your break. I think Dr. Mahabadi and I would be glad to stay here and answer any questions that you all have. Thank you for your attention.